Thank you both for your insightful contributions. We are running short of time, but we have a few minutes for questions. So if there are any questions, please raise your hands and introduce yourselves and ask your questions. Dr. Barrales.
Thank you. I have a question for Dr. Yukema. Regarding the failure of dalcetrapib, I am a bit concerned about dismissing these kind of drugs given the potential benefits that they could have in a particular subset of patients. A problem with treating all comers with acute coronary syndromes is that only with giving up smoking and treating LDL, we reduce most of the risk in a substantial proportion of patients. Do you think that these drugs could be possibly beneficial in a subgroup of patients in whom a low HDL may be an important risk factor compared with smoking and LDL hypertension?
Thank you very much. Excellent questions. And actually this addresses to the fact that we do not have a firm idea which patients do have a CETP problem and which do. Now we are treating everybody, every acute coronary syndrome or every stable patient with a CETP inhibitor. But of course it would make sense that we do it like we did in the past with statins. We start at the high end with high cholesterols, we give them statin, it works. And then you get a bit lower cholesterol and we test if statins work there, and then lower, lower, lower. And actually statins more or less seem to work everywhere. For CETP it's more complex because we do not have a clue where it actually really works. You would argue that it would work best with people with high ETP levels. Then you should measure it. In the past it was a problem. Nowadays it can be done. A lot of patients with high triglycerides and low HDL have high CETP, so you could easily argue that CETP inhibitors there might be of benefit. However, a lot of patients with low HDL alone, they have a genetic problem which causes their HDL, which has probably nothing to do with HDL. So thus far we have also no clue with CETP inhibitors that they do work if you have an isolated low HDL, and also not in this, the trial the Illuminate nor in the dalcetrapib. It didn't seem to work specifically well in the low HDL group, what you might expect, but they have probably some other kind of problem and not a CETP problem. By the way, statins do work to a significant extent, probably by lowering CETP. So the concept is okay, but we do not have a clue which is the ideal patient, and we do not have a clue which is the ideal CETP inhibitor. So we're not there.
Good morning. I have a question for Dr. Yukema. In the diabetic patients, what do you think is the role of tight glycemic control for stabilizing the plaque in the setting of acute coronary syndrome?
Sorry, I missed the first part of your question. In what type of patient?
What is the role of a tight glycemic control to stabilize the plaque in a diabetic patient in the setting of an acute coronary syndrome?
Diabetes is a very important issue, of course, in atherosclerosis because it speeds up, especially diabetes type 2. It speeds up your coronary atherosclerosis. And to link it with the previous question, actually, a lot of diabetes patients seem to have that problem of high CETP level, high triglycerides, relatively low HDL. So diabetes itself is a problem for atherosclerosis, but specifically perhaps with high CETP levels. So we should treat diabetes, of course, per se, with glucose lowering compounds, although it should not go too low because your event rates will go up instead of down. And on top of that, we should give them statins and probably something else, perhaps in the future CETP inhibitors. By the way, we always argue that every patient with diabetes has a severely enhanced atherosclerosis risk, and that is not the case. We have done numerous now imaging studies, especially with CT scans, where we have a screening program for diabetes patients, and we see a lot of diabetic patients who actually have no severe atherosclerosis whatsoever. So it's a clear risk factor, but we should not have the idea that every patient with diabetes alone has severe atherosclerosis. They need dyslipidemia, hypertension, which they sometimes or often have, but only diabetes is not enough.
Last question from Dr. Yukima to Dr. Gersh.
I was just wondering, because of your last slide was referring to weight loss, to reducing your apnea syndrome. How severely, you have shown a lot of risk factors, but how severely is that overweight problem the main risk driver? Because you showed in one of your slides a BMI of 35.5, I think. So that's severe overweight. And is that the main driver, or you say 80% of our apneic patient has such a overweight, or are you having numerous other patients who are actually pretty slim and still have the problem?
It's a good question. The answer is we do see patients who are slim who have sleep apnea. There may be a genetic variability, and I think it's an airway problem, but it's dominated by obesity. And clearly dominated by obesity, and that's why we're seeing so much of it. And I think it's driving the epidemic everywhere. I mean, I think it's driving our diabetes epidemic, and it's a worldwide phenomenon.
And is there a certain BMI level where you say here it really starts to kick off? Here you see a sharp increase?
I think probably not. It's probably a continuum, because you see the other variable is it's BMI, but there are intrinsic abnormalities in the airway. And so it may be that someone with a particular anatomical predisposition may develop this with a BMI of 30, whereas someone else needs a BMI of 40. Once you see morbidly obese patients, and we're getting up to the 35-40 range, I think they virtually all have. I do overnight oximetry in all of them. They all have sleep apnea. And there's a very easy way to diagnose it, by the way. Just simply ask the patient's spouse whether he or she has sleep apnea. And that correlates very well with the Epworth sleep questionnaire. Yeah.
Una pregunta muy corta para el Dr. Gersh. Creo que está bien reconocido que de la severe obstructive apnea está bien demostrado que produce hipertensión, fibrilación auricular, empeora insuficiencia cardíaca, pero mi pregunta iría más para algo un poco relacionado con las dos charlas, es decir, los síntomas ligeros de obstructive apnea, si podríamos considerarlo como si no un factor de riesgo de aterosclerosis, pero sí como un conjunto de confounding, como es el síndrome metabólico. Es decir, tenemos muchos pacientes severos, que son los típicos obesos, pero hay más pacientes con síntomas ligeros que tienen una morfología normal y que están totalmente desconocidos y no diagnosticados. Si esto podría ser como una especie de síndrome metabólico para la aterosclerosis.
I think that's a nice analogy. Is this like metabolic syndrome? And it may not be as dangerous as metabolic syndrome. I think metabolic syndrome is a dangerous condition. In mild sleep apnea, providing the patients, the key questions that I ask are you falling asleep in the day? Is it interfering with your job? Are you falling asleep at work? Are you tired? Have you had an accident? Especially with a farming community. You know, have you run the tractor into the side of the road? So if they don't have any of that, and you do overnight oximetry and it looks like it's mild, I might not even do a sleep study. What I would say is, look, you're 20 pounds overweight, and you need to lose the weight. Do you have a drink, a nightcap at night before you go to bed? Because you shouldn't. And why don't you just lie on your side, and your wife will thank you for that too, because you won't snore all night. So I don't think of it as I like the analogy with metabolic syndrome, but my own personal feeling is it's mild sleep apnea. I'd rather have mild sleep apnea than metabolic syndrome. And I think it's easy to treat. It's not a great deal of weight loss. It's not a great deal that they need.
Unfortunately, we have run out of time, so thank you again for your wonderful contributions. Thank you.